We're going to let a few more people come on into the room, but we are grateful to have you here this afternoon. And we'll get started. So for those of you all who don't know me, I'm Monica Lypson. I'm the Vice Dean for Education here at Vagelos College of Physicians and Surgeons. And I am delightful to be here with this esteemed group of our colleagues to talk about monkeypox. And to be quite honest, I thought we would be here talking about COVID, the epidemic that we are still dealing with expertly, and we are starting to welcome new staff and trainees here and understanding how we're going to navigate with that. Unfortunately, over the last couple of months, more and more information has come forward where we also have been put on notice with rising case rates, not only here locally in New York City, but globally around monkeypox. And so what we hope to do today is dispel a few myths, talk about how we are adjusting here at Columbia in anticipation of what this might impact our community, and also give us the knowledge and the information that we need to take care of our patients and our loved ones as we interact in this too infectious disease world. And so I'm delighted that we have the Yoko Furuya, who is here and is Associate Professor of Medicine and Infectious Disease Specialist and Chief Epidemiologist at our clinical partner, New-York-Presbyterian. And she's going to start off really talking about the epidemiology and transmission. And then our other panelists will go on to talk a little bit about how monkeypox presents, what treatments are available, where we are in terms of thinking about research, and then vaccinations. And then we'll open it up for questions, because I think we'll try to address some of those in our presentations, but we'll leave time to take some from the audience. So thank you. And Dr. Furuya, I'll let you take it away.
Thank you so much, Dr. Lypson. Next slide, please. So monkeypox has been around for decades, but up till now, very few cases have occurred outside of certain countries in Western and Central Africa. But back in May, a case was reported in England, followed shortly by numerous cases in other European countries. And the first US case was identified on May 17th. Fast forward 3 months till now, and it's really surged around the world and has now been named a public health emergency at all levels. Next slide. Here are some of the latest case counts and the relative impact across the world. You can see that at this point, the US is actually leading as the country with the most cases. Next. And within the US, New York, and in particular, New York City, is seeing the most cases. Next slide. Let's talk for a minute about New York City in particular. The graph on the left is the daily case count from the New York City Health Department website. This graph looks like it's leveling off, but I think it's a little too early to say whether that's peaked or not, because it can take some time for the diagnosis to be made for monkeypox. So the later data are still preliminary. But more importantly, the New York City Health Department has compiled a lot of very valuable information on their website about the epidemiology of the cases that are being seen here. Out of the over 2,000 cases to date, so far, they've been almost exclusively in men, including transgender men, and almost entirely in men who have sex with men. You can see the age span there, mostly in the 20s to 40s. And when you look at the race and ethnicity, Black and Hispanic populations are being disproportionately affected, which is a trend that's been reported at the national level as well. Next slide. Next. If you look at the broader epidemiology, the trends have been remarkably consistent, with the vast majority of cases being reported in men who have sex with men, both nationally as well as globally. And this is important because the epidemiology tells us a lot about how this disease is being transmitted, which is a question that many people are asking right now. I also want to take a moment to say that I know that I'm focusing on the community of men who have sex with men, and we understand that this can be very fraught, given the long history of stigmatization of the LGBTQ+ and MSM communities going back to HIV/AIDS. which is something we in the infectious disease world are very familiar with, and unfortunately we continue to see perpetuated today in the media and so on. So we do not in any way, shape, or form want to add to that, but at the same time, we do believe that it's important to speak openly and non-judgmentally about the epidemiology of this disease in order to promote our scientific understanding, as well as to formulate the right prevention strategies. But the stigma around this disease is unfortunately a significant part of the story that I'm sure we can discuss further in the Q&A. Next slide. I will come back to the epidemiology and what that teaches us about transmission in a few minutes. But first, I want to start by showing you what the CDC website says about how monkeypox spreads. And this is important because a lot of news outlets and even physicians will look at the CDC website to inform how they talk about monkeypox transmission. But if you look at this website, it gives you, as you can see, a list of all the various ways in which monkeypox can spread, including direct contact, touching objects and fabrics, and contact with respiratory secretions. This is all accurate, but what this doesn't tell you is the relative contribution of each mode of transmission, because they're definitely not all equal. But if you look at this, you might naturally have questions like, next slide. Can I get monkeypox from touching surfaces on the subway, or clothing in a store, or at a spa or gym? Next slide. Or for many of you here, can I get it in the classroom setting? Next slide. But what I want everyone to understand is that these various modes of transmission, as I said, are not all equal. We do believe that the vast majority of transmission is occurring from what is described as close, personal, often intimate skin-to-skin contact, not just with the skin of someone with monkeypox, but with skin lesions specifically. And Dr. Zucker, in his talk, will show you more about what those are in a few minutes. But can monkeypox also transmit by touching what we call fomites, meaning objects or fabric used by someone with monkeypox? And the answer is yes, but primarily this is occurring in the household setting from heavily contaminated, soft or porous items like fabrics, such as clothing, bedding, and towels, and not so much by hard environmental surfaces. And finally, contact with respiratory secretions sounds a lot like COVID, right? But monkeypox is not a respiratory virus, so you're unlikely to get it just from breathing in the air that someone else has exhaled, similar to COVID. It typically requires more prolonged face-to-face contact, such as within a household, and often in the case of intimate contact like kissing. Next slide. So you might ask, how do we know all of that? Why am I able to say that transmission is largely happening through close, intimate skin-to-skin contact with someone's monkeypox lesions? Well, as I alluded to earlier, the epidemiology is critical. We've been seeing in an incredibly consistent way that the vast majority of cases to date in this current outbreak are occurring in men who have sex with men. And from surveys and contact tracing activities, transmission seems to be happening largely from their sexual partners. Many do have anogenital lesions at the site of sexual contact, and in this outbreak, there's been very little household transmission in the absence of sexual contact. So even within a household, transmission does not seem to be happening very commonly. And finally, even when these patients are seeking out care and healthcare providers have been examining them, even without PPE, if monkeypox is not yet suspected, no transmission has been reported in that setting either to date during this outbreak. So in other words, if people were getting monkeypox in places like subways or classrooms or other public spaces just from casual contact or from touching objects or fabrics, the epidemiology would look very different, right? There would be no reason for it to be mostly men who have sex with men, and it would be more equal in terms of gender. Next. Finally, we're still learning more from virologic studies that are currently underway. But what we've learned so far is that the viral load is indeed the highest in the skin lesions, much more so than throat swabs, for instance, supporting that this isn't primarily spreading from respiratory transmission. Additionally, the virus has been identified in semen. It's still being studied in multiple other bodily fluids. And finally, when you swab environmental surfaces, any virus you pick up is generally at low levels. And when you factor in the drop-offs and viral transfer from the environment to your hands, it does not seem to be at a level where it's able to lead to infection. So I will stop here, and I'm happy to answer any more specific questions about transmission during the Q&A. But now it's my pleasure to introduce my colleague in infectious diseases, Dr. Jason Zucker, who is an adult and pediatric infectious disease specialist and clinician researcher with a focus on HIV prevention and sexual health. I should also mention that with his team, he has seen many, many patients with monkeypox at this point. So I'm excited that he's here with us today to talk about the clinical presentation of monkeypox. Jason?
Yoko, thank you very much for the kind introduction. Thank you for being with us today. Next slide. Next slide, please. There you go. So as Yoko said, this is not a new disease. And so we know a little bit about how it classically presents. It generally starts with a prodrome or symptoms before the rash starts that are really non-specific to any viral illness. This includes things like fevers, chills, headaches, feeling tired, muscle aches, and having swollen lymph nodes. Then within 5 days, but usually within days 1 to 3, the rash starts. The rash often starts on the face and spreads to the extremities, including the palms and soles. And it progresses through several synchronized stages, meaning it goes through the stages at the same time. The rash can be painful and can last up to 4 weeks. Next slide, please. So the incubation period for this disease is long, up to 21 days. That means it can be from up to 21 days after exposure before symptoms develop. However, it's usually much shorter than that, with a median of about 6 to 7 days. Next slide. And as I said, it usually starts with the prodromal symptoms, starting before the rash begins. Next slide. After that, you get this edematome, which is actually lesions in the mouth that can sometimes be painless, and you may not even know that they're there. Next slide, please. This is followed by macules, which are flat lesions. And this duration can be really short, just 1 to 2 days, so short that I don't even have a picture of macules in this instance for you guys. Next slide, please. These can progress to papules, which are solid and superficial. They really are less than 1 centimeter, so they're very small in size. And they can progress, small in size, and they can look a little bit like acne. Next slide, please. These progress to vesicles, which are still small, but can be filled with clear fluid. Next slide. And then progress to pustules, which are usually also less than 1 centimeter in size, but are filled with a darker fluid consistent with pus, or pseudopustules that are not actually filled with fluid and can be a little bit hard. They can also be umbilicated in this stage, which means they have this, this little thing in the center of them. And that's sort of the next stage. Next slide, please. Finally, as they start to heal, they begin to scab. And what's important to know is that the scabs are still contagious. And so you're not the scab falling off. Next slide, please. And there's
Dr. Zucker, could you try turning off your video, because I think your audio, you're getting a little corrupted in terms of
Sure.
sound. Okay, see if that helps.
Is that better? Yeah. So they eventually scab over and the scabs fall off with new fresh skin underneath. Next slide, please. So patients are infectious from whenever symptoms begin, whether that's the prodrome or the rash, until the lesions scab over and scabs fall off. Next slide. While that's the classic presentation, this is a slide that puts together what we're seeing during this outbreak. A couple of the things that are important to know is that the characteristic rash is common in most patients. Between 95 and 100% of patients still have the rash, while other prodromal symptoms can be less common. So patients may not be having the prodrome during this outbreak. I also want to highlight that pain on mucous membranes, like rectal pain, are much more common in this outbreak than are traditionally seen in prior outbreaks within Africa. Next slide, please. In terms of epidemiology, I think Yoko described it already. They're primarily occurring among gay, bisexual, and other men who have sex with men. The prodrome may or may not be present. And while the rash remains common, it's presenting atypically. It can start in the genital or perianal areas. It can have scattered or diffuse lesions, or can be localized to a single body site. And unlike the classic presentation, the lesions can be in different stages, side by side. Next slide, please. We're also seeing more of these severe mucous membrane presentations. So rectal ulcers that can be very painful, urethral ulcers, pharyngeal ulcers, extremely painful lymphadenopathy, eye involvement, infection, and even encephalitis. Next slide, please. It's presenting like a lot or even with other common infections. So for genital ulcer disease, it can look like herpes or syphilis. For rectal pain and proctitis, it can be very similar to gonorrhea, chlamydia, or herpes. And then the diffuse rash can look like syphilis, zoster, herpes, and it can also look like hand, foot, and mouth disease in children. So it can look like a lot of different, many more common things. Next slide, please. And this is just one more example of the monkeypox rash. Now that we've seen what it looks like, we can go to the next slide, please, and talk a little bit about treatment. Next slide, please. So most patients fully recover. It's important to know that even without treatment, most patients will get better on their own. Next slide, please. While patients are getting better on their own, we can offer them symptomatic treatment, and the CDC recently put out a great guide on how to do that. Next slide, please. And there's things we can do to help with proctitis, to provide pain relief, things we can do for genital lesions, and things we can do for oropharyngeal lesions to help support people while their body's recovering. Next slide, please. For patients with more severe disease, we can offer them antiviral medications. This includes things like patients who have severe disease, patients who have complications of their illness, and patients who might be at high risk for severe disease, like those who are immunocompromised. Next slide, please. In terms of antiviral medications, there's two called cidofovir and brincidofovir that are very similar. They've been used for years for things like CMV, and they were being tried for human monkeypox virus. However, they're not being used during this outbreak. Cidofovir, because it's considered too nephrotoxic or toxic to the kidneys. Next slide, please. And brincidofovir, which was tried in one study in England a few years ago, and they found that the first 3 patients they treated with this medication all developed elevations in their liver enzymes, and the medication had to be stopped. Next slide, please. Which means that during this outbreak, we're primarily using a medication called Tecovirimat. Tecovirimat is a novel antiviral. It uses a new mechanism of action that's specific to orthopox viruses. It was developed for smallpox and actually approved through the animal rule, meaning that it was approved just for use in smallpox. It's available to patients only through an expanded access investigational drug program run by the CDC, which means it's not like you can go to your local pharmacy and get it. There's a lot of steps involved in being able to obtain this medication. Next slide, please. In terms of what we know about Tecovirimat, we know very little about it. Because it was developed for smallpox, it was approved primarily based on animal models. We know in terms of safety that it was given to 359 patients, healthy patients in a safety study, and that there were no serious adverse events attributed to this medication. We also know that during this outbreak, it's been given to about 400 people in New York City without any serious adverse events reported. But again, it's been given to more people during this outbreak than had been given to ever before. Next slide. So while it may be safe, we know very little about its effectiveness. In fact, to date, there's only a single study published on its effectiveness in humans. It's the same study I referenced before, and even if they gave 1 patient Tecovirimat, and 1 patient who was treated with Tecovirimat had no adverse events and shorter duration of viral shedding and illness. And so obviously we need a lot more information to know if this medication is both safe and effective. Next slide. And with that, I want to turn it over to Magda Sobieszczyk, who's the Chief of Infectious Diseases here at Columbia University. I'll turn it over to you.
Great. Thank you so much. Thank you, Jason. So next slide. So I'll talk about prevention and vaccination specifically. When the monkeypox started spreading globally back in May, we were perhaps, one could say, sort of fortunate in one respect that a vaccine was available at the time. And there are actually 2 vaccines that may be used for prevention of monkeypox disease, and they're listed on this slide, the JYNNEOS vaccine and the ACAM 2000. The JYNNEOS vaccine, which has actually been approved by the FDA back in 2019 for use in individuals older than 18 years to prevent monkeypox. And then it is a vaccine that requires 2 doses. And just recently, earlier in the month, it was actually authorized for use in individuals younger than 18 years old. It is what we call a non-replicating or viral vaccine. So it's modified in such a way that it cannot replicate to cause disease. The HMPXV, in contrast, is a live vaccinia virus that is able to replicate, replication competent, and is sort of administered in a slightly different fashion, not in a kind of a typical shot, but it's administered through a 2-pronged stainless steel, kind of a bifurcated needle, which is dipped in the vaccine solution. The skin is pricked several times on the upper arm with a droplet of the vaccine, and then the virus causes sort of a localized infection or a kind of a pock that forms kind of a red, itchy, sore spot at the vaccine site, which you can see here on the slide. And that appears 3 to 4 days, and then eventually it scabs over, but it's kind of a sign that the vaccine took and is producing an immune response in the body. There is a risk of inadvertent or an unintended inoculation, and patients need to be counseled about that. And it's sort of used only in specific circumstances. Next slide. What is the current, and we call it sort of interim guidance about who may be eligible for vaccination? And I really want to note that given kind of the limited supply, and I'm really talking about the JYNNEOS vaccine here, that I mentioned earlier, because given the limited supply of this vaccine, the eligibility for vaccination really sort of changes as the outbreak evolves and vaccine supply changes. But there are 2 approaches to vaccination. So individuals may be vaccinated after exposure to someone with monkeypox, sort of a post-exposure prophylaxis, ideally given within 4 days to prevent disease. If given a little bit later after exposure, it's been shown to reduce symptoms, but may not prevent disease. And it can also be given, the vaccine can be given as pre-exposure prophylaxis. So in situations where individuals who may have certain risk factors and recent experiences that may make them more likely to have been exposed to monkeypox, they can also be considered for vaccination. Next slide. So you all have seen sort of the next couple of slides kind of show information about the public health and CDC recommendations for vaccination with JYNNEOS that can be considered for individuals who may come in contact with the virus. Next slide. And the New York City Department of Health has sort of launched a campaign to sort of open up vaccine clinics for individuals who may come in contact with the virus and may be eligible for vaccine. There, I want to emphasize that the Department of Health has actually sort of made an effort to involve community-based organizations and clinic like ours to base here at Columbia, NewYork-Presbyterian, to disseminate and kind of administer vaccination. And I want to kind of emphasize also sort of that, you know, kind of the delivery and implementation of these vaccines has been challenging because of limited supply, but it's been really important to make them accessible at sites where people are at, especially kind of at local CBOs, and doing so kind of in a non-judgmental and non-stigmatizing fashion. Next slide. So the current recommendations in terms of the dosing, and we're talking about the JYNNEOS vaccine here, is that the standard regimen, which is listed on the at the bottom of this table, involves a subcutaneous injection kind of into the fat layer of a volume of half a milliliter. And that's really been approved by the FDA since 2019, as I mentioned. And just recently, this standard regimen has also been authorized for individuals younger than 18 years old. Very importantly, in the context of this current national public health emergency, an alternative regimen was authorized last week and may be used for people older than 18 years old. And this alternative regimen actually involves an intradermal injection kind of right under the skin. And we can administer a smaller volume that has been shown in earlier studies to sort of produce a similar immune response, but it is dose sparing, so it can conserve the vaccine doses. Next slide. So big question always is, well, how effective is a vaccine? Do we have any data about that? So actually, the first evidence that a smallpox vaccine can also protect against monkeypox really comes from a study that was done in 1980s, which showed that among patients' contacts, smallpox vaccination was about 86% effective in preventing monkeypox as well. But so far, this was sort of with older generations of vaccines, and so far there's sort of scant data on how well the vaccine is working in the current outbreak. So much more to be done. Next slide. Next slide. And what about how long does the protection last following vaccination? Again, much remains to be learned. We know that peak antibody responses were seen in the blood about 2 weeks after the second dose of this 2-dose JYNNEOS vaccination series, but we don't know how long this protection lasts. We do not recommend routine antibody titer testing to confirm successful vaccination in immunocompetent individuals. And we also we don't know how sort of high an antibody level is needs to be achieved in order to ensure protection. That data is still accumulating and is not currently known. Next slide. Just one note about co-administering the JYNNEOS vaccine and concurrently with other vaccines, because that may come up in clinical practice or as individuals are being advised about COVID vaccination, for example. So typically, the JYNNEOS vaccine may be administered without regard to timing of other vaccines. There may be some additional considerations when administering it at the same time as a COVID-19 vaccine. So the JYNNEOS vaccine should not be delayed because of a recent receipt of a COVID-19 vaccine. There doesn't have to be any minimum interval that needs to pass between COVID and the JYNNEOS vaccine. However, in younger adult or young adult men who male at birth who may potentially consider waiting a little bit of time following a monkeypox vaccination and before receiving the COVID-19 vaccine, because there's been a low but observed risk of myocarditis or pericarditis, so inflammation of the heart after the ACAM 2000 orthopox vaccine and COVID-19 vaccines. And we don't know whether that risk happens and exists for the JYNNEOS vaccine. So it's just a note of consideration and discussion with one's providers. Next slide. I mentioned, and you've been hearing throughout what Yoko and Jason have also been saying, that there are still a lot of outstanding questions and research questions and clinical questions that remain to be answered. And that really has to do with improving the screening for monkeypox, and wastewater monitoring is an active area of research, and we've been in discussions about that. Also really understanding the transmission dynamics and best diagnostics for this virus, improving testing, including self-testing, which will be incredibly liberating for our communities. And also understanding what is the extent of secondary or household transmission that Yoko was mentioning. Much remains to be learned about treatment in terms of the best supportive measures for individuals who are presenting with symptoms. And also a big question is about Tecovirimat itself. Does it work? And does viral resistance develop? And I'm saying, we're fortunate to be able to launch a clinical research study that's funded by the NIH that will be starting hopefully soon. And Jason is one of the co-chairs of that protocol. So we'll be learning much more through the conduct of this study. And a lot of questions about vaccines also remain in terms of what are the optimal doses. I mentioned to you the intradermal and subcutaneous dosings, duration of protection, and also equitable dissemination of information about vaccinations, and making sure that we have access for everyone who may wish to and who may need to access it. So a lot of questions remaining. I think we're really excited to be partnering with many individuals at the medical center to answer these questions. So much more to come in the weeks in the future. So let me end with the next slide, where I'm just listing the fact that there are lots of resources available at the medical center for questions about testing, vaccines, and treatment. We're happy to serve and answer any questions you may have. And I'll turn it over back to you, Dr. Lypson.
Thank you, and Student Health on Haven is also available for both testing and counseling for our learners. We've got a few questions in the chat, and I'll try to combine some of them. But since we just finished talking about vaccine, there's a question about, could you say something about the diluted dosage, the 1 to 5, a dosage for the vaccination plan. And then also there's a question in the chat about the immunologic difference between, say, intradermal presentation of sort of, if you think about pox and cowpox and the whole story about inoculation around smallpox versus a standard either subcutaneous or intramuscular injection.
Yeah, so I can talk a little bit about this. So there was actually, this was back some maybe about 15 years ago or so. There was a publication. So first of all, kind of I should say, sort of the intradermal delivery of vaccines has been, it's not new. It's been part of practice, kind of clinical practice before, and it's sort of, what's attractive about it is that it may require sort of a lower dose of the vaccine compared to administering through intramuscular or subcutaneous dose. There was a study from 2015, so about 10 years ago or so, that actually sort of compared the intradermal versus the subcutaneous delivery of the JYNNEOS or the MVA vaccine, modified vaccinia Ankara vaccine. And it's sort of the results of the study, and again, it was not an incredibly large trial, but it sort of showed that the immune responses generated by the intradermal vaccine were not inferior to the kind of immune responses that were seen after subcutaneous injection. And that's kind of given us confidence, and given the FDA and the Infectious Disease Society of America confidence that these approaches can sort of result in similar immune responses while being dose sparing.
And then any thoughts about the reduced dosage vaccination plan in order, we've heard a lot in the news about, given the scarcity of the vaccination.
Yeah, so, and Jason, you can comment on it as well, because it's an active area of discussion, because, it's an attractive approach, but I think one thing that that needs to be ensured is that providers are trained in administering the vaccine intradermally, because it's a less common mode of administration. But I think it's kind of, given the scarcity of the vaccine and how many individuals could be eligible to receive it or would want to receive it, I think it's an important step to be taking at this time while production ramps up. Jason, did you want to add anything else? You're on mute.
Yeah, of course. I think that's exactly the right point, is, we need to increase production, but we have data because, they've been studying this for smallpox for years. In case of smallpox, they want to make sure you could extend doses. And so they have immunologic outcomes that are equivalent. So I think it's a very reasonable thing to do when we don't have enough dosages, as you said, while trying to produce more.
So, and I'm going to redirect lump a few questions more about clinical presentations, transmissibility, et cetera. So there's a question about what happens to pregnant people. Is there transferring of the virus across the placenta? And then also about the rash and the pustules. Is there a permanent scar sort of there afterwards?
So I can take a couple of those. So there are reports of perinatal transmission from mother to child. You do have viremia, or virus, in the blood during this disease, and there have been reported poor fetal outcomes in those cases. So that's certainly something we're worried about. Yeah, so you can have that. It doesn't happen every time, but it certainly can happen. In terms of the scarring, I was just on a call this morning with a group of dermatologists working on trying to figure out what the best approach would be to reduce scarring. because the expectation is we'll see scarring in this disease. You know, one of the challenges that we're actually only a few months into this outbreak, and scarring can actually take a long period of time to occur. So after the scab falls off, you actually have a period of redness where it's recovering, and the scarring can actually take 4, 8, 12 weeks before you really see it. So we don't know yet, but the expectation is that some patients will have scarring, and we want to do everything we can to reduce that.
And then just a couple of questions about children. So one is there's been some more cases of children with monkeypox. Could you elaborate on how the virus might either be more severe, less severe? Do we have any information on that? And then start here.
I guess I'll take this one also. So there's two, strains of the virus, the clade 1 and the clade 3. Most of the outcomes we have in children are really in the clade 1 virus, which is the more severe virus. And children under age 9 did have worse outcomes in that one. Right now, and hopefully it will stay that way, there have been extremely few children infected. I think I heard today that it's now 7 in the United States total, and that's out of a large number of infections. And so far, all the outcomes have been very positive. And hopefully we'll stay that way.
All right. And then Yoko, as we sort of think about there's a couple of questions about sort of, we're all moving to a hybrid lifestyle in the workplace. So if I'm hoteling and sharing my desk space, if I'm sharing materials in the workplace, at what level should people sort of think about monkeypox potentially as a problem? And then if you're at home, what temperature do I have to make sure the dryer's set at, or should I been thinking about things like that in terms of laundry, et cetera, towels?
Sure. So regarding things like shared workspaces, hotels, that sort of thing, again, it kind of comes down to what I was saying around what we know about the epidemiology and what we know about the virology. From the epidemiology side of things, it's not been described that that monkeypox has been transmitted through shared spaces. And from, again, the virology perspective, it does not seem like, again, when it comes to hard environmental surfaces, that monkeypox really transmits very readily from those kinds of surfaces. We do have to be a little bit more concerned about porous materials like fabrics, which can hold on to pathogens a little bit more readily than hard surfaces. And so when it comes, the recommendation is that if somebody has monkeypox, then they should be laundering their laundry with hot water, which generally is in the 160-degree range. Hot water is always the best way to disinfect your linens and towels and so on. But this is a enveloped virus as opposed to a non-enveloped virus. So it's actually not very difficult to kill when it comes to detergents, disinfectants. Laundry also involves mechanical friction, which can help remove pathogens from surfaces. And again, there's no reports of transmission. I think, again, we would be expecting to see it in a much wider epidemiology if it were spreading through towels at a gym or that sort of thing. We do recommend not sharing towels, however. So that's just something to keep.
And then can you talk a little bit about transmission in the healthcare space? And you touched on it a little bit in your slides, but when does a healthcare worker need to be concerned about taking care of a patient with monkeypox or needing to have access to the vaccine?
Yeah, absolutely. So I think that, again, in this current outbreak, there has not been any reported healthcare transmission. And this is the case even in the beginning of the outbreak, where before people really knew that monkeypox was spreading in countries where it had not previously been recognized as being common. So I think that is somewhat reassuring. I think some of the other things that help us in the healthcare setting are things like universal masking and universal PPE when caring for patients, hand hygiene, all of those things can be very effective. But yes, whenever we do ask that whenever somebody suspects monkeypox, that they do take all the precautions, place the patient on isolation precautions. And then the recommended PPE at this time is still full PPE, N95, eye protection, gown and gloves, really, to be as cautious as possible. When we do identify that somebody has been inadvertently cared for that wasn't suspected to have monkeypox and all the PPE was not worn, in the hospital setting, infection prevention and control does work with the individual to identify kind of what exactly the interaction was, and then classify based on CDC classification of how high the risk is. The highest risk exposure is thought to be direct ungloved contact with a patient's skin lesions, which again, in the healthcare setting, we always say don't touch non-intact skin with your bare hands. You should be wearing gloves as part of standard precautions, but let's say it happened. In that case, recommendation would be for the JYNNEOS vaccine for post-exposure prophylaxis. And that is something that, infection prevention and control works with the health department to make sure that we get that for the healthcare.
And then just to follow up on that, there's a question about those of us who are faculty at the dental school or doing dental procedures. Any thoughts about how that might impact dentistry?
Yeah, I think that's a great question. And I think, again, it comes down to all of the universal PPE precautions that I think that most clinical areas are taking, including dentistry at this point. So things like wearing eye protection, things like wearing masks and N95s, wearing gloves, all of those things that are protective against COVID, we believe are also, if anything, even more protective against transmission of monkeypox.
And then just before we go back to some questions about those who are immunocompromised and other questions about the vaccine, recommendations on sort of hard surface cleaning, household cleaning, is the same products available that we have been using for hard surface COVID available should be fine with monkeypox?
Yeah, absolutely. Household disinfectants, things that have alcohol or quaternary ammoniums, those are very effective in killing the monkeypox virus. Again, this is not a virus that is particularly difficult to kill, thankfully. So all of the usual disinfectants that are out there are effective. And
the gym wipes. There's many people doing their wellness in the chat, and so I want to make sure the gym wipes would those cover that as well.
I'm sorry, what was that?
Wipes, wiping down hard surfaces at gyms.
Oh yes, right, correct. Same idea. Again, in a lot of these situations, the friction is also effective, as well as the actual disinfectant. So within the combination of both, it really should be effective. And I think it's always a good practice, whether there's monkeypox around or not.
Thank you. And then just back to some questions, a little bit about how we should be, if we find a patient or ourselves who have a diagnosis or suspicious of monkeypox, what is the isolation or quarantine period, just so that people can think about that. And then we can talk a little bit about how we will address this for our trainees.
Sure. So people are thought to be infectious from the time that the symptoms begin, which is, in some cases, the prodromal symptoms that Jason mentioned with fever and swollen lymph nodes and so on, all the way up through when the skin lesions have crusted over, the scabs have fallen off, and intact skin has developed. So after that point, a person is no longer considered infectious. But it can be anywhere from, Jason, what have you seen in terms of wide ranges of how quickly this happens for different people?
Yeah, anywhere from 2 to 4 weeks. So it does take a little bit of time.
And then there's a question in terms of our trainees. So Student Health on Haven is aware of these protocols. They're able to both test on Haven, and they're also able to counsel our learners. and they should use the absence policies for all the schools to put in place to sort of be able to accommodate their studies if they're not ill. So each school has a different approach to that, and it should be handled appropriately, knowing that the quarantine period is a bit longer than others. There's a few questions that we will be posting this webinar as well as the slides a little bit later for those who were interested. And then there's some questions about there's people that are old enough as myself who have that scar on my arm from smallpox. So should older folks who have had the smallpox vaccine be worried in the same way that others? And then a lot of questions about how this might look in those who are immunocompromised, either via cancer, other drugs, HIV, et cetera.
Yeah, no, that so both Jason and I can answer that. And I had it on my slide, but I sort of glossed over that. So individuals who may have had kind of, as you pointed out, Dr. Lypson, who may have had vaccination, some more than 3 years ago, let's say. The current recommendation is sort of more than 3 years ago, is that they may not be it's unknown whether sort of prior kind of smallpox vaccination, how long the protection lasts, and it probably wanes with time. So for individuals who've either been sort of exposed or are in a group where they would warrant kind of vaccination for monkeypox, even if they've had childhood smallpox vaccine, if it's been more than 3 years ago since vaccination, then kind of post-exposure prophylaxis would be recommended.
And thoughts about those with an immunocompromised state, and in terms of the vaccination, one series versus two doses, thoughts about that?
Jason, do you want to, because we've had a lot of discussions about that, and I can tell you that the data are not crystal clear, but Jason, do you want to summarize a little bit? Yeah.
Sure. I think saying the data is not crystal clear is probably the best summarization. But I think what's important is that for patients who are immunocompromised, they are at greater risk of severe disease if they become infected, and so will benefit from vaccination. And the recommendation is for immunocompromised individuals to get 2 doses of vaccine. So even though they're prioritizing first doses, immunocompromised patients can get a second dose.
And then in particular, if someone has had monkeypox, at what point, we talked a little bit about the quarantine period being 2 to 4 weeks, but at what point are they not considered infectious and can resume either sexual activity or more intimate activity than prior?
Yeah, I think so. Again, once the scabs have fallen off, the skin lesions, as Jason described, the progression, eventually the last point is that the scabs form, the scabs then fall off, and as long as intact skin is there underneath, then they're no longer considered infectious, and they at that point can resume their normal lives in terms of work or sexual activity, et cetera.
And then there's a particular question about reinfection for patients who were prescribed Tecovirimat.
Yeah, and that's so reinfection and or maybe even kind of a recrudescence, right, of the virus, whether it's because perhaps it could sort of mutate under the pressure of the medication, and then lesions may reappear or symptoms may get worse over time. So again, this is sort of why doing a clinical study is important, where this information can be sort of collected systematically and then analyzed with all the caveats, because we are starting to hear reports of individuals who are being treated with Tecovirimat, and some following, some days or even close to sort of finishing treatment, they've had a recurrence of a lesion or maybe a new lesion that kind of emerged, right? Jason, I know we had a patient like that, and then our colleagues in New York reported small number of cases. So is it that the virus has kind of mutated from under the drug of the pressure and and reappeared, or reinfection. It's not entirely clear. Jason, do you want to add to that?
Just I think we're learning a lot about the disease. You know, it hasn't transmitted in this particular way before, and we haven't studied it well outside of some of the countries it was endemic. And so I think we're going to learn as we go, and these guidelines will change and update as we learn more.
And then just on the early access program, there's a question about who's the manufacturer and has the IND been applied for here?
So there's an expanded access program through the CDC. And the expanded access program through the CDC has been available here now since mid-June. And so we've had it available on site for people here since then. The research study is separate from the expanded access program, because I'm looking at the question, is separate from the expanded access program, and there's an IND for that as well. So that's a different process, separate from the expanded access program.
Yeah.
Thank you. And then could you, Jason, just to go back a little bit about, it's that time of year, school's restarting, and the thought about children and the also common presentation of hand, foot, and mouth and other infectious diseases as school starts back. Your thoughts in general about that?
You know, I'm getting a lot of calls about hand, foot, and mouth disease right now because it's really that time of year. I think a couple things are, you know, if you have something in your child that you're worried about, you should first bring him to the pediatrician. Most pediatricians will recognize hand, foot, and mouth, and it doesn't look exactly like human monkeypox virus. It has a pretty classic appearance. And then if the pediatrician's unsure, we can always do a swab to make sure. And I think that's the key to this whole thing. You know, right now it's very unlikely to be human monkeypox virus in a child because it just not supported with the epidemiology. But we wouldn't want to miss any. And so if there's a lesion that doesn't look classic or looks unusual, it makes sense to swab it just to be sure and to be safe.
And then fortunately or unfortunately, this is a zoonotic virus, which was transmitted from monkeys to humans. Should we be worried about transmission from humans to other species?
Yeah, I believe that has been reported. So yes, I think in both directions. So I think originally most infections of monkeypox in humans occurred from contact with infected animals, and that can still happen. But there is also some data to show that animals can transmit that humans can transmit to animals as well. And I believe there have been cases of human to dog transmissions and so on.
Thank you. And then any thoughts about if you've been infected with monkeypox, conferring immunity? So we talked a little bit about the treatment and resurgent potentially, but it doesn't matter which clade. Is it clade 1, clade 2A, or clade 2B?
So how does sort of if natural infection, what kind of immunity does it sort of confer for someone and for how long? We don't know. I think that's kind of a simple answer to that question. And again, I think that's why kind of doing follow-up of individuals who've been infected and may have required treatment or not is going to be important to kind of see how long, how durable protection is from natural immunity, and then kind of compare it to vaccination. Yeah. Because this, yeah.
Go ahead.
No, I'll stop here because there's still sort of a lot that we're kind of learning about this particular kind of virus. Yeah.
And then there's a question, we've talked a little bit about the skin manifestations, but other manifestations, ocular or other places on mucous membrane.
Mm-hmm. Jason, do you want to talk about it? Because we've had cases, certainly. Yeah.
So we've had cases of all of those different areas so far. So far, our outcomes have been good in the short term. I think, you know, following these patients and making sure there's no long-term complications is going to be something we're learning because these are really new presentations. But so far, our short-term outcomes have been very positive.
Mm-hmm.
So I am just going to ask us in the last minute to sort of summarize some of the questions. I heard that in terms of day-to-day contact, that the current things that we do to keep our hard surfaces clean and washing and laundering our fabric materials, clothing should be protective in the workplace or in the educational space. Is that the interpretation?
Yes.
In the audience.
Yes.
Yes.
And then for those who are infected, we do have access here, both on the Columbia campus for Columbia doctors, but also as part of NYP, to get our patients, if not our colleagues, access to the treatment and the vaccinations.
That's absolutely correct. And we've been very fortunate kind of to be able to mobilize resources that have existed kind of in the clinic and through our clinical trials unit here in the division to sort of to make the treatment vaccines accessible to kind of our kind of broader community as well. And we've also been caring for a lot of individuals who are Spanish prefer Spanish language. So we've been able to deliver that services to kind of our community around us, which there's always more that we need to do and can do, but it's been a great team effort.
And then is there anything else that we need to let our community know about monkeypox? And are you willing to come back as things change and we get more up-to-date information?
So we would love to come back. I think, because it's also, just as we were kind of mentioning, there are a lot of questions that remain, and we'd love to make sure that we sort of, kind of present kind of all the up-to-date information in a very transparent fashion, and kind of give people opportunity to ask questions. And there are lots of partnerships that have kind of formed actually over the last sort of weeks in terms of kind of dissecting kind of the epidemiology, the virology and clinical presentations, and the follow-up of individuals who present with monkeypox. So yes, we'd love to come back.
Yeah, I wanted to add that we've definitely learned with emerging infectious diseases such as COVID, as well as monkeypox, that the information keeps changing. And so we always kind of have that caveat. This is based on what we know right now and what the science tells us now. And as it evolves, we appreciate the opportunity to keep everyone up to date.
And then just for clarity's sake, there's the last question that came into the box. There is a scarcity of the vaccination. So we are not vaccinating anyone that doesn't have sort of a near contact or probable cause in terms of thinking they might be infected at this point in time due to the shortage of vaccinations.
That is
world. In fact, it's not a local problem.
It is not a local problem. It is a global problem, as you said. Yeah.
All right. Well, thank you so much. It is always exciting to be here at Columbia, where we have the experts giving us the latest information, and you really using our expertise in terms of research and clinical care to deliver up-to-date information to our community. So thank you all.
Thank you. Thank you for having us.
Thanks for having us.
Thank you.